Hello, and thank you for tuning in to Answers from the Lab, where we share Mayo Clinic knowledge and advancements on the state of testing and science from laboratory leaders and the people who are making it happen behind the scenes. I'm Dr. Bobbi Pritt, Interim Chair of the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. With me today is Dr. Bill Morice, the President and CEO of Mayo Clinic Laboratories. This is our weekly discussion with Dr. Morice, in which we learn about updates in the field of laboratory medicine and pathology.
Bill, how are you doing this week?
I'm doing great. A little sleep deprived because of the new puppy, but it's all worth it, and things are good.
Good, yeah, and all those holiday parties, those have been fun.
Yeah, indeed.
So puppies and parties, it's a great time of year. Well, we have some big announcements from the FDA that I thought would be good to talk about this week. Of course, we've been covering the FDA updates on their proposed rule for making it explicit that lab-developed tests are devices. At least that's what the rule would amend the FDA regulations to clarify. So as we've discussed, the comment period closed on December 4th. Well, we'll have to wait before we hear any updates on that. But it was interesting. I noted that the Office of Information and Regulatory Affairs published their unified agenda that indicates they intend to publish the final rule by April 2024.
Yep. Yeah. So I think it's coming. There's been other changes at FDA. Tim Stenzel, who I think we worked in that part of FDA, CDER, Center for Diagnostic Radiology and Devices, or whatever that stands for exactly. The alphabet soup that are the government agencies. But, he was someone that we had known personally. They've brought in a new person, so that will be providing kind of medical scientific advisement. So, yeah, I think all signals are pointing that they're really going to push towards publishing the final rule. Of course, they'll have to at least address the comments in the public record in some way, shape, or form. They don't have to actually change, they don't have to change what they intend to do. They might, but we'll see. But so that's a lot of work. They have a lot of work on their side as well. So more to come. Well, it'll be very interesting over the next several months to see how this evolves.
Absolutely. And I think the major point for our listeners is the aggressive timeline that April of 2024, which is not that far away now, is when they have the goal of publishing this final rule.
Yep, exactly.
So there's that. Now,
there's that.
On a very different note, we also just learned that on December 8th, the FDA approved 2 milestone treatments for sickle cell disease. And I thought this was right up your alley. And, before we even get into what these treatments are, maybe you could tell us a little bit about sickle cell disease. And then these 2 treatments are gene-based, so we can kind of get into the specifics and what that means for people with this terrible disease as well.
So first of all, we do have in our hematopathology division here in DLMP in Rochester, we have the metabolic hematology lab, which tests for all these different hematologic hemoglobinopathies, I guess is the best way to put it. And sickle cell disease is one of those. It's caused by a mutation in the beta chain. Remember, hemoglobin's a tetramer with 2 alpha chains and 2 beta chains. And in sickle cell trait, one of your beta chain genes has a mutation, which actually, if you just have one, if you're heterozygous, it doesn't cause disease, and it actually probably helps protect you from malaria. So it's more common in Mediterranean, Sub-Saharan Africa. Those places. We've been there more than I have. But if you have 2 copies, then you get sickle cell disease, and that means when the blood gets into a low oxygen, like in the capillaries, in a lower oxygen tension setting, that the cells get an abnormal shape, and they actually turn into what looks like a sickle, hence the name under the microscope, and those don't flow through the capillaries. And so what happens then is that it can cause lack of blood flow. It's very painful, can actually cause necrosis in organs, or hypoxia. So it's a big problem. And so one of the things that you look for when you're trying to treat patients with sickle cell disease, if you have a high fetal hemoglobin, so in utero, we have a different hemoglobin F, which actually binds oxygen really strongly. That's what allows oxygen to go across the placenta into the baby. So if you have a persistence of that hemoglobin F, if it doesn't go away in the first year of life as it's supposed to, it actually protects from sickling because it keeps the oxygen high in the blood. Or if you somehow, for some reason, have more excess of the normal beta chain for whatever reason, then you can get the balance back. So if you get some normal hemoglobin in there, usually it's by transfusion. So a lot of these patients end up being chronically transfused right now, is how they get treated.
Yeah, so all these different types of hemoglobin. So I guess hemoglobin A would be the normal type, right?
That's correct. Yep.
But they have hemoglobin, someone that is homozygous, that have both copies of the sickle cell gene, have hemoglobin S, 2 copies.
Yep. Yep.
One copy would be sickle cell trait, both copies sickle cell disease.
Exactly, which can be a real problem, and it can cause necrosis of the hip, for instance, and other. Really, it can be very, very much. It can be a disabling disease.
And then hemoglobin F, what you have when you are a fetus, which is also good, except that the babies usually stop making it when they transition over to hemoglobin A. So this is important. I'm reviewing all this because it's important to remember when we talk about how these 2 new therapies actually work. So let's get into the therapies. The 2 treatments that are approved have long names, and I'm going to do my best to pronounce them. So the first is called Casgevy, or maybe it's Casgevy. The long name is hexagamglogene autotemcel, and thankfully we could just call it Exacel for short. So Exacel is very novel because it's the first FDA-approved gene editing cell therapy using the CRISPR-Cas9 system. So fascinating. It is only approved for people with sickle cell disease that are 12 years or older that have had recurrent vaso-occlusive crises, these really painful crises you just talked about, Bill. It's made by companies Vertex and CRISPR Therapeutics, and what it actually does is it edits the gene that usually turns off the production of hemoglobin F. And that gene is called BCL11A. So it goes in and edits that particular gene. It deactivates BCL11A in bone marrow stem cells that you've taken from the patient. So now they start making hemoglobin F again. So it's really kind of ingenious. Usually hemoglobin F, I seem to recall it binds oxygen really, really tightly, and hemoglobin A might be a little better for adults, but if you don't have hemoglobin A and you just have hemoglobin S, well, hemoglobin F kind of comes to the rescue and allows these patients to pretty much have normal functioning hemoglobin, or at least normal lives without these pain crises. Yeah,
it's all about the oxygen balance. So and the genetics of this gets really complex, how these things get turned on and off. But there is a disorder called hereditary persistence of fetal hemoglobin, HPFH. There are drugs which can elevate hemoglobin F2, which are currently what's used. But if you have HPFH, normally you don't even know it. You might just get detected for some other reason. But if you have sickle cell disease, it actually prevents you from actually having the clinical manifestations. For exactly, again, it goes back to that physiology. In utero, you need your blood to be able to get oxygen from your mom's blood, so your hemoglobin is even stronger in attracting that oxygen. In an adult, what it does is it means there's more oxygen in the bloodstream out in those capillaries. So even if you have 2 copies of the beta gene, the oxygen tension is probably high enough that you don't sickle there. I think is really what that's my understanding of the mechanism of action. Anyways, irrespective, it is definitely protective. And so what this does now, they basically genetically making a person with sickle cell disease have hereditary persistence of fetal hemoglobin and be protected from it.
Yeah, it's fascinating. So they take your own stem cells and they treat them with this therapy, turn off the gene that usually suppresses hemoglobin F. So now these stem cells start making hemoglobin F. You get enough of these stem cells that are modified. Then you destroy the rest of the untreated bone marrow, and then you reinfuse the edited cells. So a little bit of a risky procedure because you do have to wipe out all the bone marrow. but you have this store of cells, you've just edited it and you reinfuse them. And the goal is that they take over, they produce hemoglobin F, and now the person has the ability to actually get enough oxygen and not
Yep.
have these painful crises.
That's right. And then remembering too, for people that don't, for the way the bone marrow works is you have these pluripotent stem cells that as they grow, they become either white blood cells or red blood cells, right? So they're going
Yep.
to those stem cells, and the ones that turn into red cells then will have this hereditary persistent HPFH. Easier said that
Yeah.
way. Kind of genetically engineered HPFH.
So there's all sorts of opportunities for this therapy. They've actually, the companies that have worked on this, tried it in patients with beta thalassemia as well, a different type of hemoglobinopathy. This was not part of the FDA approval, but it also seems to work for them. So I think we're going to be seeing more of this type of gene therapy getting approval through FDA.
That's right. And then the other therapy, of course, I think actually just takes out the hemoglobin S gene and actually introduces genetically, or I don't know if it takes out the S gene, but it definitely genetically introduces normal hemoglobin or a normal
Yes.
version, a genetically engineered normal version of hemoglobin.
Yeah, the other one is even harder for me to explain. It's a bit more complex, but the other therapy that was also received FDA approval on December 8th is called Lovo-cel, also known as Lyfgenia. And it's made by a company called Bluebird Bio, and it uses more of a traditional approach with a viral vector, a lentiviral vector that is just a gene delivery medical vehicle. It's also approved for patients with sickle cell disease 12 years or older with a history of vaso-occlusive events. And what this does, you still take out those stem cells, those pluripotent stem cells from the patient, so it's their own cells, but then they are genetically modified to produce a version of hemoglobin A. So different than the first one where they're basically producing hemoglobin F. Now these cells are genetically modified to produce hemoglobin ATH7Q, which is a gene therapy derived hemoglobin, and it functions very similarly to hemoglobin A. So two different ways to get a good functioning hemoglobin into these stem cells. And then of course they can be reinfused into the person. And now you have functioning hemoglobin, no more painful crises.
That's right. And again, I think both of these involve some kind of uh, at least a potential ablation is what we would call it
Yes.
medically, but knocking out the stem cells that you were born with because they have this genetically hemoglobin S disease to try and get you to the right balance. Because it's interesting. It's all about, you don't have to completely get rid of S. You just have to have enough normal hemoglobin or enough hemoglobin F around to make sure that the cells don't take this abnormal shape when they get onto the capillaries, right? So
Right.
it's makes it a really probably a good candidate for the first gene therapy, but it does raise questions as well, because this is the first gene therapy that's going to be approved by the FDA. It really it ushers in a new era that will have great potential for alleviating human suffering, but also raise issues around bioethics, which we've
Yep.
talked about with AI as well, right?
Yeah, absolutely, Bill. They followed these patients out for 1 year so far, at least with the first therapy we discussed. There doesn't seem to be any negative side effects, but we don't know that for sure. And it should be a permanent fix, but they've only shown positive reactions for 1 year. So there's that. The possibility that there may be negative side effects that are unforeseen, and yet we are probably going to continue forward with these new types of therapies, and we're probably going to see more approvals. I would not be surprised if we saw one for beta thalassemia in the future by the same companies. And so it raises those ethical issues of, should we be going in and manipulating genes, inactivating genes, inserting genes? And it also
Yeah.
talks about access. These are expensive therapies, and arguably the people that need them are those that are living in very resource poor areas that probably will never be able to afford these therapies.
Yeah, I think the one lay press publication estimated about $2 million from one of these therapies.
Yeah.
and again, as you and I talked about before we started the podcast, I worked in the Federal Medical Center here in Rochester, so the federal prison, medical prison, and that's where I had much more experience with actual patients with sickle cell disease, because it tends to, in the U.S., it tends to affect African Americans, right? It's more prevalent in sub-Saharan Africa than it is, in Mediterranean as well. So I'm Mediterranean descent, but it really is a disease that's just found more in populations that we know already suffer from some disparities in healthcare and healthcare access issues. So is it going to actually widen that gap? That's going to be who's going to pay for this. Those are all the issues and the other thing I think we'll see hotly debated is, where do we draw the line? Who makes a decision about what things should be candidates for these therapies? Do we just leave it to the pharma companies? Is there some kind of ethical oversight required? Almost certainly, right, to consider these things. That's why, on the one hand, from a laboratory perspective, the FDA oversight of LDTs is something that it's we're still trying to grapple with, right? But on the other hand, these agencies were created because really there's the intent is to really be thinking about the public good. And so and there's a lot of that. And it's for us to just in healthcare to be voices for both, that we need to continue to innovate, create new diagnostics and new therapies for our patients to alleviate suffering. But on the other, is to really keep the needs of our patients and society first, and really thinking about and being part of that dialogue about how the best ways to do that.
Yeah, I agree, Bill. Our podcast today kind of shows two different sides of this coin with regulation, and really it's all about keeping our patients safe, and we're worried about regulation that's stifling, but at the same time, regulation that's protecting patients. And you could foresee that companies outside of the United States, smaller countries with money, resources, they could be offering therapies that people will travel to get. And it raises the question of some of these ethical issues. Should you get like a designer baby? Pick your own eye color. Anyway, that's a ways off, thankfully.
That's a ways off. The closest I'll come is picking out a Norwich Terrier to start to breed terriers. There is no gene editing involved there whatsoever. So
just the old-fashioned way, right?
That's right.
Well, Bill, thanks as always for a really interesting discussion.
Yeah, thank you. As always, there's no shortage of things for us to talk about. That's for sure.
Absolutely. We'll be here for you. All right. See you later.
See ya.
Thank you so much for tuning in to Answers from the Lab. Be sure to subscribe to this podcast, and don't forget to tune in every Thursday and every other Tuesday.